Hello, everyone, and welcome to today's webinar, Recurrent Pregnancy Loss, featuring Dr. Sara Arian from Boston IVF. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you by Harvard around midsummer. Now, without further ado, I would like to introduce today's speaker. Dr. Sara Arian is a double board certified in reproductive endocrinology and obstetrics and gynecology. Dr. Arian earned her bachelor's degree at University of Toronto in Canada, received her medical school degree from Iran University of Medical Sciences, completed her obstetrics, gynecology, and reproductive sciences residency at the University of Texas Health Science Center in Houston, completed her fellowship in reproductive endocrinology and infertility at the Cleveland Clinic and Baylor College of Medicine. Wow, that's a lot. She received her master's in clinical research at Baylor College of Medicine. She is an expert in all facets of reproductive health and fertility care, including robotic and laparoscopic surgeries. She has a particular interest in fertility preservation for cancer patients and reproductive and fertility sparing surgeries. All right, we're going to get started. I'm going to pass it over to Dr. Arian.
All right, thank you for this nice introduction, Alyssa. Good afternoon, everyone. I am delighted to be here today to talk about recurrent pregnancy loss and the stigmas and dilemma surrounding it. So I am going to get started. And allow me to okay, sorry, just trying to advance my slides here. All right, so taking a minute for my slides to advance. There we go. All right, so the objectives of today's talk are to define recurrent pregnancy loss, also known as RPL, to become more familiar with the risk factors, prevalence, as well as underlying causes and etiologies of RPL, to become more familiar with when to start evaluation and what are the recommended testing and evaluation for recurrent pregnancy loss, to identify the role of lifestyle factors, as well as to become familiar with different treatment and management options for RPL. So what is the definition of RPL? So there are definitions and guidelines as implemented by the American Society for Reproductive Medicine, or ASRM, as well as ESHRE, which is the European Society for Human Reproduction and Embryology. As per the recommendations and definitions by ASRM, for the diagnosis of RPL, an individual needs to have 2 or more than 2 early pregnancy losses. These are losses of a clinical pregnancy, which is documented by ultrasound or histopathology, that do not need to be necessarily consecutive or back-to-back. These do not include early biochemical pregnancies and or pregnancies of unknown location, as well as they do not include ectopic pregnancies and molar pregnancies. As per the ESHRE guidelines and definitions, an individual needs to have 2 or more than 2 early losses, less than 24 weeks of gestation, losses that are confirmed by early urine pregnancy test or serum HCG. Again, they do not have to be consecutive. They can include early biochemical pregnancies as well as pregnancies of unknown location, but they typically do not include ectopic or molar pregnancies. And when to consider workup and evaluation for RPL, and based on ASRM and ESHRE, in the setting of having had 2 or more than 2 early losses, it is recommended that we start evaluation for recurrent pregnancy loss. What is the prevalence of recurrent pregnancy loss? First trimester sporadic pregnancy losses are more common than what most think of. So I tell patients that up to 1 out of 4 or 25% of pregnancies can end up in an early loss sadly, unfortunately. And the risk of loss can depend on a woman's age, number of previous losses, causes of losses, and history of previous live-born infant. Majority of these losses, as we know, are due to chromosomal and genetic abnormalities. Less than 5% of individuals will experience 2 consecutive losses. Less than 1% of patients will experience 3 or more than 3 consecutive losses. What is the prevalence of future losses and miscarriages after having had a previous loss? And so I oftentimes, again, get asked by the patients this question: how likely am I to experience another loss after having had previous miscarriages? And the answer is that the percentage of having a future miscarriage or miscarriages will increase with increased number of previous losses. So as you can see here, having had 3 previous losses will put you at increased risk of 29% of having a future miscarriage with the next pregnancy, while this percentage can go up to 53% likelihood for experiencing another loss after having experienced 6 previous losses. So again, it is recommended that evaluation for RPL should be started after having had 2 previous losses. And I can tell you that most REIs, including myself, consider biochemical pregnancy in this setting in order to start an early evaluation, meaning a patient does not necessarily have to prove to have experienced multiple clinical losses before the physician can start evaluation and testing. What are some of the etiologies and underlying causes for recurrent pregnancy loss? And again, as we all know, the most common causes are chromosomal abnormalities, which include chromosomal aneuploidies, abnormal number of chromosomes, as well as chromosomal structural abnormalities. Some of the other etiologies and underlying causes include structural or anatomical causes, immunological factors, as well as endocrinopathies, infectious etiology, thrombophilia and clotting disorders, environmental factors. And it is interesting to know that over 50% of early pregnancy losses will have no identifiable cause, and these are idiopathic or unexplained losses, even after extensive workup and evaluation. So 60% of early losses are associated with chromosomal and underlying genetic related etiologies, which is the most common cause for most RPL cases. Karyotype testing can be done on products of conception, and this is commonly done in the setting of individuals undergoing a surgical DNC after experiencing a miscarriage. But unfortunately, clinical genetic testing remains unhelpful at times because it rarely includes molecular studies which show promise in helping to further elucidate the exact mechanisms for RPL. And of the examined products of conception, approximately 60% of early losses are associated with sporadic chromosomal abnormalities and anomalies, and these are primarily chromosomal trisomies that are the most common type, that are usually age-related and a result of increased and advanced maternal as well as ovarian aging. Some of the limitations of testing of products of conception include maternal contamination of the specimen that can commonly happen. In addition to the failure of these karyotype testing to identify other causes of RPL, including non-cytogenic embryonic causes for recurrent pregnancy loss. And it is interesting to know that most studies show that most cases of recurrent pregnancy loss are likely to be euploid even after adjusting for maternal age. All right, so let's talk about structural chromosomal rearrangements that are categorized into balanced structural chromosomal translocations as well as Robertsonian translocations. And these translocations or chromosomal rearrangements should be considered as an underlying cause of RPL in about 2 to 5% of cases. Balanced reciprocal translocations, these usually occur when pieces of genetic material break off from two different chromosomes and swap places. Because of the balanced exchange of chromosomal material between the two non-homologous chromosomes, there's no really loss of genetic material or no phenotypic effects and impacts on the offspring or on the individual. With Robertsonian translocations, these translocations usually occur when two chromosomes join together to form one large chromosome. And instead of having 46 chromosomes, we end up with 45 chromosomes. And this type of translocation involves usually acrocentric chromosomes, and these are chromosomes 13, 14, 15, 21, and 22. And just a reminder, a chromosome is acrocentric, where the centromere is not centrally located, and instead it is located near the end of the chromosome. These chromosomal rearrangements and translocations are found on parental chromosomal karyotype testing, and in these cases, we commonly refer patients to a genetic counselor. Now, with Robertsonian translocation, just to go into a little more details, as I mentioned, it results from breakage of two acrocentric chromosomes or close to where they break, close to where their centromeres are located, with subsequent fusion of their long arms to form one chromosome. So the short arms of each chromosome is lost, but this is not really of a clinical significance. The total number of chromosomes, again, in this type of translocation is reduced to 45. And in a person who's a carrier for a Robertsonian translocation, about 1 out of 4 of the offspring are normal. 1 out of 4 are carriers of the translocation, but they're balanced, so they're phenotypically normal. And then half of the offspring end up having an unbalanced duplication, which results in a trisomy, and the other half will end up having an unbalanced chromosomal deletion, which will end up in a monosomy. Other structural chromosomal abnormalities include chromosomal inversions, and inversions are chromosomal rearrangements that involve only one chromosome typically. In an inversion, a segment of a chromosome is flipped and reinserted upside down, so to speak. People with an inversion may create embryos with missing or duplicated segments of chromosomes, and so they are going to have exchange of genetic material between the two different chromosomes that can happen with chromosomal inversions. So how do we approach this and overcome this? One treatment option for couples with chromosomal translocations includes PGT-SR for specific translocation, which is pre-implantation genetic testing for chromosomal structural rearrangements. We do this pre-implantation genetic testing on the embryos through IVF or in vitro fertilization with transfer of an unaffected embryo. And the other option would be using a donor gamete. PGT-SR is a genetic test that can determine whether embryos that are created through IVF have chromosomes that are arranged abnormally or not sized correctly. And typically the likelihood of having a subsequent healthy live birth with IVF and PGT-SR obviously depends on the chromosome that is involved and the type of the rearrangements. Clinical pregnancy rates after transferring a normal, unaffected embryo diagnosed with PGT-SR in most cases would be similar to transferring a euploid, basically embryo. And that would be pregnancy rate as high as 70% in these individuals. Other causes of RPL include anatomical or structural causes of RPL, most commonly congenital uterine or Müllerian abnormalities, and these can include a wide spectrum of anomalies, abnormalities, including unicornuate uterus, bicornuate uterus, uterine diadelphys, as well as uterine septum. These are more commonly seen in patients with RPL. With the uterine septum being the most common congenital Müllerian anomaly. that can be associated with 65% of early pregnancy losses. Bicornuate uterus is the second most common congenital anomaly that can be associated with 36% of early losses. These anomalies, as we know, are also associated with other poor outcomes, including second trimester pregnancy losses, in addition to other OB complications, including increased likelihood for preterm birth, fetal malpresentation, and increased rates of C-section. Other anatomical causes include intrauterine adhesions or synechia, also known as Asherman syndrome, as well as uterine fibroids or leiomyoma and uterine polyps. As for diagnosis of structural and anatomical abnormalities, there are different types of diagnostic imaging modalities that we use, including 3D ultrasound, sonohystogram, hysterosalpingogram, or the HSG test, diagnostic as well as operative hysteroscopy, and in more complicated cases, pelvic MRI can also be ordered. Management depends on the underlying etiology. For uterine septums, large uterine septums, we usually proceed with hysteroscopic septum resection. In the cases of Asherman syndrome, we typically perform hysteroscopic lysis of intrauterine adhesions. Polyps can be removed typically hysteroscopically by performing an in-office or operative hysteroscopic polypectomy. And fibroids, depending on their size, exact location, the degree of their impact on the uterine cavity, as well as their proximity to endometrial cavity. Sometimes removal of the fibroids has to be considered when managing patients with recurrent pregnancy loss. Let's talk about immunological factors that can result in recurrent pregnancy loss, with the most common being APLS, or anti-phospholipid antibody syndrome. There is a criteria. There is a diagnostic criteria for diagnosis of APLS that includes clinical as well as laboratory criteria. And at least one clinical and one laboratory criteria must be present for the diagnosis. Prevalence of APLS, by the way, is about 15% in individuals experiencing RPL. Clinical criteria, just to summarize, includes history of vascular thrombosis, having had 3 or more than 3 consecutive losses, less than 10 weeks of gestation, 1 or more than 1 unexplained loss beyond 10 weeks of gestation, and or history of previous preterm birth, 34 weeks or earlier, due to preeclampsia or basically any kind of uteroplacental insufficiency. And then there's also laboratory criteria, including lupus anticoagulant, anticardiolipine antibody, and anti-beta-2 glycoprotein antibody. And it is important to note that it has been recommended to check these serum antibody levels at least twice, at least 12 weeks apart. So standard treatment for APLS, as we know, includes administration of low-dose aspirin and heparin, which can result in about 74% live birth rate. And this is superior to treatment with aspirin alone, which will result in about 43% live birth rate. Prednisone has not, and steroids really have not been shown to improve pregnancy rates and outcomes, and may be associated with increased risk for developing gestational hypertension and gestational diabetes, and we don't typically use them in the management of APLS. We typically start patients with APLS on daily baby aspirin while they're trying to conceive, and heparin will be started in the form of Lovenox, prophylactic Lovenox, 40 milligrams daily, typically with a positive pregnancy test, with the first positive pregnancy test. What are some of the endocrinopathies that are associated with RPL? So it is generally agreed that maternal endocrine disorders, including diabetes, thyroid dysfunction, and PCOS, should be evaluated and treated as long as there are signs and symptoms suggestive of these conditions. There's really a lack of consensus and a lot of debate and controversy in our world of REI regarding the definition of a normal upper limit of TSH and normal thyroid function. And I can tell you that for most of us, based on the guidelines of the ASRM, we would consider treatments for subclinical hypothyroidism in the setting of having TSH levels of 2.5 or higher with presence of thyroid antibodies, or TSH levels of 4 and higher without presence of anti-TPO or other thyroid antibodies. Uncontrolled diabetes can be associated with increased risk of pregnancy loss as well as insulin resistance, which by itself is a risk factor for RPL. PCOS or polycystic ovarian syndrome can also be associated with about 30 to 50% likelihood for having a spontaneous early pregnancy loss. There are several etiologies and hypotheses for this, and some of them include elevated levels of luteinizing hormone or LH, elevated levels of androgens, which can result in altered endometrial environments as well as impaired endometrial receptivity that can then result in impaired implantation. Insulin resistance and metabolic abnormalities, as well as obesity and elevated BMI are also some of the other factors that are associated with PCOS and increased likelihood for having RPL. Prolactin can also be associated with recurrent pregnancy loss, prolactin and prolactin abnormalities. Prolactin is commonly measured in patients with RPL because elevated prolactin levels are not only associated with ovulatory dysfunction and anovulation, but hyperprolactinemia can also be associated with RPL through alterations in the hypothalamic pituitary ovarian axis. Studies have shown that normalization of prolactin levels with a dopamine agonist can improve subsequent pregnancy outcomes in patients with RPL, while treatment can result in about 85% in some studies live-born rate compared to about 52% live-born rate in untreated patients. Here in this table, I would like to talk about some of the guidelines implemented by the ASRM as well as ESHRE in regards to testing, hormonal and metabolic testing when it comes to evaluation for RPL. And there are some differences here between the two societies. So in regards to thyroid testing, ASRM supports routine screening for thyroid stimulating hormone or TSH without necessarily having to test thyroid antibodies unless someone has risk factors for having autoimmune thyroid disorders, while ESHRE supports testing for both thyroid function, TSH, as well as anti-TPO testing. Is there a true association between thyroid antibodies and recurrent pregnancy loss in euthyroid women? And this is again controversial. In some studies, it has been reported that patients with primary recurrent pregnancy loss had a higher incidence of elevated levels of anti-thyroglobulin antibodies and or anti-TPO antibodies. Prolactin, we talked about this. It is recommended that we test for serum prolactin levels by the ASRM. In the absence of other symptoms, ESHRE does not recommend this. And then there's hemoglobin A1C and glucose screening, which is recommended by the ASRM, but not by ESHRE. There are also some tests and some testing that I would like to talk about that are not recommended by the SRM or ESHRE, any of our national guidelines, when it comes to evaluation for recurrent pregnancy loss. An interesting one is screening for thrombophilias, clotting disorders, including factor V Leiden, protein C and S deficiency, antithrombin 3 deficiency, MTHFR, which is really controversial, as well as serum homocysteine levels. And really, ASRM or ESHRE and ACOG do not support routine screening for thrombophilias in the setting of RPL. The only caveat is in the setting of having had personal history of venous thrombosis with a non-recurring risk factor, or having had a first-degree relative with inherited thrombophilia. When it comes to infectious testing, including ureaplasma, mycoplasma, or testing for chronic endometritis, this is not something that is supported by the ASRM or ESHRE guidelines. Ureaplasma, mycoplasma, as well as toxoplasma, listeria, and even bacterial vaginosis are found to be more frequently found in vaginal and cervical cultures of women with recurrent losses. However, there's really no convincing data, and antibiotic prescription is oftentimes not helpful in these settings, and so we don't typically routinely test all individuals. And then there's also sperm DNA testing for fish, screening for sperm aneuploidies, as well as sperm DNA fragmentation, and these are not really standard testings that are recommended, again, by most of our societies. We know that sperm age and male age can have an impact, based on some studies, on the outcomes of pregnancy, and can have an impact on the incidence of pregnancy loss impacted by paternal age. But in general, we know that male age has minimal effects and impacts on pregnancy outcomes. Some of the other tests that are not recommended are testing for endometrial receptivity. There's a test known as ERA, or endometrial receptivity array, as well as endometrial biopsy, again for chronic endometritis or any infections. Routine PCOS testing in the absence of any signs and symptoms of PCOS, as well as routine prescription of metformin in cases of RPL without any evidence of insulin resistance is not recommended. Routine testing for luteal phase deficiency is not really recommended. It is very controversial, and there's really no definitive testing or diagnostic testing that can be offered or done in order to identify and diagnose a short luteal phase. And then vitamin D testing routinely is not recommended, although that we know that there's a higher prevalence of vitamin D deficiency in women with RPL. And I can tell you that a lot of our us REIs do like to check vitamin D levels in all individuals with soft fertility, infertility, and with recurrent pregnancy loss, and we treat individuals with serum vitamin D levels less than 30 nanograms per milliliter, which is by definition vitamin D deficiency. And then immunological testing, complex testing, including HLA typing, natural killer cell testing, which is offered by some centers, cytokine testing and HLA polymorphisms. These are not really recommended. They are oftentimes very pricey, costly, and can be a burden for many of these patients to be tested for. And we know that a lot of immunological factors, including and treatment options, including IVIG, steroids, as well as granulocyte colony stimulating factor, are really not efficient in the treatment and management of patients with infertility or with recurrent pregnancy loss. An interesting topic that comes up with recurrent pregnancy loss is the role of administration of progesterone in minimizing the risk for having a subsequent miscarriage. So in 2015, I like to talk about this trial because in 2015, there was a very nice randomized controlled trial done on progesterone use in patients with RPL, and this was published in the New England Journal of Medicine. This was a very well done, multi-center, double-blind, placebo-controlled randomized trial in order to investigate whether treatment with progesterone would increase the rates of live births and newborn survival among women with unexplained recurrent miscarriages. So individuals with unexplained recurrent pregnancy loss in this study were randomly assigned to receive either progesterone or placebo. Their primary outcome was live birth after 24 weeks of gestation, and the secondary outcomes included clinical pregnancy as well as ongoing pregnancy and miscarriage rates. So this study had a lot of aspects to it, but in conclusion, just to kind of summarize, based on the study, progesterone therapy in the first trimester of pregnancy did not really result in a significantly higher rate of live birth among women with a history of unexplained recurrent miscarriages. And so, again, per the ASRM guidelines, the data on the use of progesterone supplementation for recurrent pregnancy loss is conflicting and controversial. Administration of progesterone to women with sporadic miscarriages is oftentimes ineffective. However, ASRM states that in patients with 3 or more than 3 consecutive miscarriages immediately preceding their current pregnancy, it is not going to hurt to use empiric progesterone, and this administration of progesterone may be of some potential benefit in this patient population. So I oftentimes tell patients that progesterone is readily available, accessible, not expensive, overall harmless, minimal side effects. And so if it is going to have some potential benefits, most patients are willing to use it and to try it in the setting of recurrent pregnancy losses, typically 2 or more than 2 losses. What are some of the impacts of lifestyle factors on recurrent pregnancy loss? I know a lot of us commonly get asked these questions, and are lifestyle modifications going to be helpful in this setting? We know that smoking can be associated with RPL. It does decrease chances for having live birth. It does have vasoconstrictive impacts as well as anti-metabolic effects. BMI changes and extremes, including obesity, being overweight or underweight, have been associated and reported to be associated with RPL and poor OB outcomes. And then alcohol, obviously, is a well-known risk factor for pregnancy loss, as well as fetal alcohol syndrome. One, again, question is that we get asked commonly is about stress. Is truly stress associated with recurrent pregnancy loss? And so stress can be associated with recurrent pregnancy loss, but really individuals should be informed that there's no evidence that stress is a direct cause for pregnancy loss, as we all know. And this is something true with the cases of subfertility and infertility. Caffeine, if it's consumed at high doses, more than 3 cups per day, which is typically more than 200 milligrams per day, has been associated with about 25% increased risk and likelihood for having an early miscarriage. And then exercise, obviously it's great to implement a healthy lifestyle as well as exercise. However, there's no conclusive evidence that routine exercise will help minimize the risk or the likelihood for having a recurrent pregnancy loss. So let's talk about psychological factors, psychosocial factors surrounding RPL. Pregnancy loss has a huge psychological toll on affected individuals and couples, as we all know. There's increased sensitivity to that effect that is necessary, we have to keep in mind throughout regular follow-ups and evaluations of these patients. Recurrent pregnancy loss patients are prone to heightened anger, depression, anxiety, feelings of guilt and grief. And all of these patients should be offered psychological support and counseling. And studies have in fact shown significant improvement of subsequent pregnancy outcomes with close monitoring and emotional support of these patients. So bereavement and grief support is extremely important for these patients. Based on a survey-based questionnaire, individuals were asked about their most important needs immediately after having experienced a loss. And 45%, most patients said that they are wanting to have more information and wanting to know the exact causes of their pregnancy loss. 26% of them reported that they do have an important need for family and emotional support, while about 12% of patients on this survey reported that they would like to know how to prevent from a future pregnancy loss happening. So there's also unexplained recurrent pregnancy loss, and it is interesting because even after extensive evaluation and workup, no apparent causative factor is identified in about 50 to 75%, up to 75% of couples and individuals with recurrent pregnancy loss. The important thing to know, and the good thing, positive thing to know, is that for patients with unexplained RPL, the chance for having a future successful pregnancy can be as high as 50 to 60%, obviously depending on maternal age and previous parity. Again, another positive aspect here is that most patients with RPL will end up having a live birth. So as it is demonstrated on this graph, for patients with 3 previous miscarriages, the likelihood for having a live birth within the first 5 years can be as high as 75%. This likelihood can be lower, still as high as 60% for individuals with 6 or more than 6 previous losses. So really, at the end of the day, hope and optimism can help these patients get through their negative experience with early losses. So in summary, the majority of miscarriages are sporadic and are thought to result from genetic causes that are greatly influenced by maternal age. Recurrent pregnancy loss is defined by 2 or more than 2 failed clinical or early pregnancy, and up to 50% of cases of RPL will not have a clearly defined and identified etiology and underlying cause. For assessment of recurrent pregnancy loss, we need to focus on chromosomal analysis. This is achieved by performing a peripheral chromosomal karyotype analysis for both partners, both parents, as well as screening for antiphospholipid antibody syndrome, assessing for structural anatomical abnormalities, including imaging studies, sonohystogram, HSG, hysteroscopy, screening for endocrinopathies, routine screening for thyroid, prolactin, and other endocrine abnormalities based on presenting signs and symptoms. And knowing that most patients with RPL will end up having a live birth, and that psychological counseling and support, including emotional support, should be offered to all of these patients with RPL. So with that, I am going to end my talk, and I would like to thank you all for attending and listening, and I'll be happy to take any questions.
Thank you, Dr. Arian. We are now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your panel in your attendee control panel. The first question is, after how many miscarriages do you recommend, do you recommend sending a patient to an REI after 2 losses, or should we try to do some of the workup first?
I think both. I think, depending on obviously your practice and what you feel most comfortable with. I see many patients that are being referred by their primary OBGYNs after having had some basic evaluation done. Most basic testing being anatomical structural evaluation, a vaginal pelvic ultrasound, sonohystogram, even an HSG, as well as hormonal testing, including thyroid function, TSH, prolactin, as we talked about. Some may even have had their chromosomal karyotyping done through their primary OBGYN. But I'm also happy, we're all happy to see patients who are directly referred by their primary OBGYN for RPL workup without having had any previous workup done.
Thank you. The next question is, do gestational carriers play a role with RPL, and where do you see them fit in?
That's a great question. So I would say in the world of reproductive medicine, and obviously human reproduction can be very complex, as we all know. If I'm seeing a patient who we have, offered different types of testing to basically overcome RPL. Let's say we have done IVF, they have already created euploid genetically tested embryos by having undergone pre-implantation genetic testing. Let's say we keep failing euploid embryo transfers after having had all the workup done, which sometimes our workup can be extensive. Sometimes we have to throw in all these add-on testing, which may not necessarily be supported by evidence. Then at that point, it's something that we would discuss with the patients. Some decide to proceed that route earlier. Some, will have a hard time emotionally accepting it, but it certainly can have a role once we have obviously screened and checked for everything and there are no other causes other than some issues, some underlying cellular, molecular issues going on at the level of the uterus endometrium, which obviously we're not capable of testing for.
Thank you, Dr. Arian. That was our last question. Thank you for attending today's webinar, Recurrent Pregnancy Loss. If you have any other questions, you can contact myself, Alyssa Cooper, at ecooper@bostonivf.com. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you could complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF and Dr. Arian, thank you for joining us today and enjoy the rest of your day. Thank you again, Dr. Arian.
Thank you for having me. Bye.